and it's a great pleasure to welcome you all again. And this is a very, very interesting session focusing deep dive ASCO 2025 and focusing on lung cancer, what's new. It's a great pleasure to welcome and invite the program convener, Dr. Vamshi Krishna, Director and Head Medical Oncology and Hematology at the prestigious Institute of Oncology, AIG Hospitals, Hyderabad. So once again, good evening, everyone. Just give us a couple of minutes. In next 2-3 minutes, the flow will be there with Dr. Vamshi, and then we will do a kickstart.
Good evening, everybody, and welcome to the ASCO Deep Dive session on lung cancer. The ASCO Deep Dive program was conceived as a method of analyzing the important abstracts which were presented in a particular subject in the ASCO every year. Needless to say, not all of us can attend the ASCO, and it's always good to dig out the clutter and try to find out what are the best studies and trials which have implications for treatment in India as well. So without further ado, I welcome the first speaker, Dr. P.P. Sahu, and welcome his panelists, Dr. Akhil Kapoor, Dr. Suman Karant, and Dr. Ullas Batra. Dr. Sahu, over to you.
Yeah, thank you, Vamsi, and I'll share my screen. So it's now full screen and I'm audible.
Yes, sir.
Yeah, sure. So I see Suman, I see Akhil, and Ullas messaged me that he'll be joining in a minute. So someone let me know when Ullas has joined. So it is about early lung cancer. We have been given a mandate, all four of us, to discuss what has happened in the early lung cancer, and we are restricting to the first half an hour to the driver mutation positive lung cancers. So it was the topic was first adjuvant, but we felt appropriate because of the new adjuvant space has lit up actually in this field, and two abstracts were presented. So with the consent, we are going to discuss this and also take the adjuvant data, and let's see how can we, is it mature enough for us to change practice, or is it very exciting, and and will we be able to adopt it as soon as possible, or would the panel like to wait further for more mature data? Let's now find out. So without much of delaying anything,
sir.
yeah, I saw him. उल्लास जब आता है तो सब खिल जाते हैं. So okay, so we have a T3N2 M0 non-small cell lung cancer, del-19 positive. So these are the treatment options. Ullas, what would you do to? What have you done today with this patient which you saw Mr. X in the OPD today? With this, what would you do? And the options are here. Everything is there. What is possibly there? What would you do to this patient?
Okay, sorry for joining late. So we have a T3 N2 M0. So N2 is a multi-session.
For the discussion sake, let's put it because at a single session N2.
At a single station.
Yeah,
Operable, inoperable, patient fit, not fit.
It is operable.
It is operable. Patient fit.
Patient is fit, the PFT is good enough, and your surgeon can operate if you want him to operate.
Surgeon can operate if you want a single session N2.
If you want him to operate.
Fair enough. Single session N2.
Yeah.
Patient fit. I will go for surgery followed by Adora, sir.
Okay. So in this case, you'll go for surgery followed by Adora. Akhil, any different answers? Would you like to go for a neoadjuvant approach, or today with that data which has been there in the last 10 days in our domain, would you like to think of something?
So definitely there's an option which has opened up, but has it changed our practice till now? It is unlikely it has changed our practice till now, because the primary endpoint is based on major pathological response. But yes, thankfully we have an option. If the patient is somewhat, surgeon is dicey about the fitness, surgeon wants to utilize chest physiotherapy and other options, I would be happy to give either single agent osimertinib or OC plus chemo
Okay,
based
so
on
basically
data.
we'll come to that. So basically
Yeah.
what I get from you is you are
Sure.
also agreeing with Ullas.
Yes.
On your routine clinical practice, you will still go for surgery for such a patient who's del-19 positive. For the rare cases where there's a fitness issue and or surgeon wants to wait and there's some other issue with the patient wants to think over, you would not mind probably, but your go-to is surgery. That's what it is. Suman, any different, or do you want to add something?
Sir, I agree with whatever Dr. Ullas sir says. Whatever he
You
says
have to agree to that.
in
That's
the
so
lung
done.
space. So I would, as of today, the data, I mean, I'm sure we will be discussing the data, but as of
Yeah.
today, surgery first followed by
Okay. So now let's move forward, and I'll just put the set the context, and that's something. Ullas, I know your answers. I have heard you moderate about Adora a lot of times. So I'll start with Suman and then go to Akhil and then go to Ullas on this.
Thank you for
Are you
that.
convinced that all the patients who were in Adora, Suman, are eligible? And in your practice, do you feel that yes, this is something I'll give to a stage 1B?
In Adora, yes, I am.
Adjuvant. We just leave the new adjuvant for a minute. Let's now first come to a conclusion on Adora, and then we'll go to the new adjuvant part of it.
And Adora, you mean all the 1B, the 2 and the 3A, all the
So
stages?
would you be giving it to a 1B patient?
I would give it for 1B
Okay.
patient as well.
You would give. Akhil?
Yes, sir, I will also give. And now we have also trial for Adora 2, 1A2 and A3. Let's see the results.
Okay. Ullas?
Sir, 1B, I will hold my horses for that.
Okay.
I mean, 1B, I'm not yet convinced right now for 1B, but 2 and 3, I will give, sir.
Yeah. So I knew his answer, and I totally, that's how I also practice. We'll come to why there's a lot of difference, and all the three all the discussants are actually correct. But to be fair to everyone, yes, there is approval. If someone does it in 1B, it's not wrong. You have a all-comer approval from 1B to 3 as per the Adura inclusion. But there is something which we need to be there, which we need to discuss about it. Ullas,
शक्ल तो दिखा दो
हाँ?
सर शक्ल तो दिखा दो
अरे बैंडविड्थ कम है शकल
अच्छा।
बाद में देख लेना
आपकी बैंडविड्थ तो
second
बहुत
point
ज्यादा है
is-
सर अच्छा आपका जो इंटरनेट है उसकी बैंडविड्थ कम है
30
आपका तो
मिनट
बहुत ज्यादा
मेरे
है
को
सर
दिया है चुप रह so basically now let's come down to a very important thing. Akhil, will you give adjuvant chemotherapy? Because there is a data, although that was a analysis which was not pre-planned, but the data just comes out and we look at the numbers as such and look at the percentage of patients at the disease-free survival and the OS benefit at that point with chemo, without chemo, it's dot on. Nothing has changed much with additional chemo. Although
Yes.
people expected adjuvant chemo to add something at least in the stage 3 patients or 2B patients. So what do you think? Would you give chemotherapy based on the size, or let's say you have a TP53, would you like to add chemo to this patient, or would you go for osimertinib alone?
So, sir, if there is a concept of P53 under part, there it is chemotherapy plus osimertinib. We cannot sequence. The data is not enough for sequencing. So the problem is that we know in EGFR mutation positive patients, the data from metastatic setting is clearly suggesting osimertinib is definitely much better than any chemotherapy. So I think I will be spot on directly start osimertinib as soon as feasible.
So for you,
That's it.
most of the patients in adjuvant will be no chemo going for osimertinib, more
Most of
like the alectinib data set. What is there?
Yeah,
Either
correct.
chemo. Ullas, any different? Quick yes, no. If yes, why?
Sir, I think I would, wherever the indication for chemotherapy is there, I would like to give chemotherapy. I think there was a subset which says people who get chemotherapy are actually doing better than people who did not get chemotherapy. Again, in in the ADAURA trial, people who did not get chemotherapy was early stage. Chemotherapy is sidle, I would, I mean, and osimertinib
Can I stop you here? Because I really checked into this stage-wise chemotherapy thing. And there is nothing in the publication that really distributes the chemotherapy as per the stage.
I will send you across, sir. It
Okay.
came in one of the subset
And
analysis.
then second
Also,
point, if you look at the Kaplan-Meier, it is dot on the percentage.
correct, sir. But still, sir, I think in EGFR mutant non-small cell lung cancer is not ALK positive lung cancer. We cannot let go of chemotherapy. I'll offer the patient, all the patients chemotherapy who are fit for that. If a patient is not tolerating chemotherapy well, I'll be happy to stop it at 2 cycles, 1 cycle, 3 cycle, but I will definitely offer them that.
Suman,
Especially
whom do you agree with? You have a now difference of issues, and both of them are right actually. And the point Ullas is making is adjuvant chemotherapy has stood a test of time. It has been holding. We have been doing it for 1 decade, 2 decades nearly. I would not let go of one data set, and which was not the primary endpoint of the data set as such. And I would give the benefit, and EGFR is not as forgiving as ALK positive disease. The two things what he spoke about.
Yes, sir. So I'm not privy to the data which Dr. Ullas sir is saying about stage 3 chemo. So I'm not aware of that. So probably when he sends you the slide, sir, please send it to me also. As per ADAURA, what I understood is that it is osimertinib. Yes, there is that P53 population, TP53 population, which always develops resistance. And probably in this subset, maybe
there is actually no analysis on ADAURA on the TP.
Yeah.
Yes,
We
I
don't
just
have
want to
any
be
data
clear.
for 53 from
I just
ADAURA.
put in that thing just to take the decision forward, because that is the very in thing. And that is the most common mutation if you start doing NGS broad panel.
yes.
Around 40-50% will have a coexistent TP53.
42% in our
Yeah.
data.
So that's the point. So Suman, for you, I get it that you are not disclosing your cards, but you think that chemo is not that important. So here again, there's a difference, and I can tell you both of them are right in the field, but most of the experts still believe that ADAURA was not designed to answer this question.
Yes.
You just cannot let go based on one analysis which is there. What Ullas is telling, I have seen that data set, but I could not read the text. There is a little more DFS on numerical values with the chemotherapy arm. So it's
So I
very,
think
very
it's 3 to
marginal.
4%, sir.
Yeah.
3 to 4%, but definitely, sir, something which has been, as you have been telling, time tested, proven. I will want to definitely go ahead and I'm not letting go of chemotherapy just because, and if the patient is fit enough to undergo surgery, should be given chemotherapy. It's a sidle drug. Just, and especially because of our next question, 3 or more years of osimertinib.
Yeah, you take it because you're through. Yeah.
Correct. So the stage 3 disease, I will like to go ahead with, and especially with LAURA trial with, at the time I counsel my patient, I'll say, there has been a good amount of drop after the 3 years are finished. Approval, I know is for 3 years.
So if I can interrupt you here, that the point you're telling me is you would like to give it based on the quantum of data that's being adding on with LAURA, and also the graph of Kaplan-Meier which has been there with the ADAURA post the cessation. That's what you are pointing to.
In
Suman?
stage 3, definitely. Stage 1, I'm anyway not giving. Stage 2, so there was a trial in Nature which was published which says ctDNA karalo.
Yes.
So if we have a technique which it says ctDNA, keep on monitoring ctDNAs regularly, when it increases, stop-start approach. I don't think in India, I am not very confident that a lot of labs are doing it in the right way. So in a stage 3 disease, I will definitely counsel my patient for prolonging. Stage 1 disease,
and you'll give it with a consent that there is no approval. You're doing okay, fair enough. Suman, what Ullas is pointing to is a March 2025 beautiful paper, and I think people should read this. It is a post hoc analysis. Point number 1. Point number 2. Two things have come out of paper. First thing that has come out is once you stop, and the MRD was positive around 8% only in the baseline, not a huge number of patients post surgery have MRD positive. The second thing in the paper that really strikes out is that once you stop on the osimertinib arm, the patients actually around 25% of patients start getting MRD positive, and most of them get within the first 12 months. And they have a lag period of around 4 to 5 months before you get into the scan positive. That's a 4.7 exactly, with a range of 2.2 to 6 months. So odd. So what Ullas is pointing out is what I also wanted to, and I and Akhil spoke about it 1 year back. Akhil, if you remember, in Mumbai, the best of. So I put a scenario. You have a stage 3 positive patient who comes to you from a Delhi center where people are fascinated to do ctDNA, and at 3 years the ctDNA is positive. Would you want to push this patient to counsel for more of osimertinib, especially on the graph that is there, that the dip starts after you stop, with the MRD data now published, all this is a post-hoc analysis, and also the LoRa, which has the concept of giving it for continuous.
I completely agree. In such situation, it will be prudent to counsel the patient for continuing it for longer duration as much as feasible, and definitely it is.
Suman, quickly, yes, no.
Sir, I would continue for stage 3, but not probably in the earlier stages. Even when they did the earlier TKI in this family, the TKIs, that is the afatinib, even there they saw the moment they stopped it in the adjuvant setting, and within 2 months, actually, the disease started coming back. So I think stage 3, stage 3 diseases 3 and more. So, and I will say that
so for everyone who's there in this, listening to us, there are 2-3 things. What we have spoken for this at least is beyond approval. Number 2, this is something people should go back and read the Nature paper. It's free access, and this is not spoken about enough in our forums. But this is a beautiful written paper, and a lot of things are there actually in this paper. Number 3, what is being pointed out is that it's a tissue, it's a tumor agonist ctDNA. You have that time actually, and the depth of coverage, and what you are having is they are not sure of the technique, and there has been failure in around 7 to 8% cases. So not everything is very sorted out in this field. But yes, what Ullas and everyone of the panel is speaking about is in the stage 3, especially high risk patients, you would be little pushing with the data that has come up with multiple trials. So I'll just skip this and go to one more last question on Adora.
Even in stage 2, we can also consider.
It's just the concept is there for both the stages. If the concept of ctDNA really is there, it will be for both the stage, and there is also a osimertinib phase 2 data for 5 years. Let the data mature, the target data, and then we can have further more discussion on that. Ullas, you wanted to say something on this.
The one important point, as you had rightly said, was that isme na shuru mein it doesn't make a difference.
Yeah.
It is at the end of 3 years. I mean, that is also a point which people should realize. You know, people say we will do surgery and then we'll see ctDNA was MRD was positive or not, and then we'll do. In that trial, they found out only 8% of people had MRD
8%
positive
for MRD positive post surgery.
If I remember rightly, yes, sir.
Yeah, and actually there is one more trial going on for stage 1A to stage 2A. They're pushing osimertinib pushed to stage 1A and till 2A, and they're doing MRD. If it is positive, then they're doing observation with osimertinib. That trial is ongoing. We are not going to speak of that. Let the trial mature.
There is also one trial about 3 years versus 5 years, sir. But I think you should realize one thing, that, correct me if I'm wrong, I have not read Adora for a long time, but I think only 60 to 70% of people finished adjuvant osimertinib at the end of 3 years. So it's not that it is osimertinib and people will take it. Even in trial, not many people are taking it regularly. So I think we need to
spend one more question on this. If we go to Neo Adora, that's the thing we want to discover next 10 to 15 minutes. Last 10. Can you tell one criticism, Ullas? Why would I am not happy? I would like not to give adjuvant osimertinib. One point in my favor.
You will not make the adjuvant osimertinib in all these 3?
Yes, all stages. Let's say stage 2.
Okay. What is the 5-year survival is 85?
So my point was, are you happy with the subsequent treatment for such a trial? Because if you look at it, and it's very fair, it is only 40% of the patients who receive osimertinib, which should have been a standard of care. You see, Laura, it is 85 to 90% receive that treatment. That gives the robustness to the data set. If let's say everyone would have received 80-90% would received on relapse, do you think the OS curves would have been different?
It would have been different, sir, but that is not the way trials are designed actually, and that is not the way the real world really works. So Adora say people learn. In fact, in Laura also they gave it indefinite.
Laura, it is around 80 to 90%.
Yes, so in crossover they allowed, and even in Neo Laura there was a trial amendment which says in adjuvant we will give.
Yeah, we will come there.
I agree with you,
This
sir.
is one big criticism for
But
Laura,
Dr.
for
Sahu,
Adora.
sir, I'll tell you one thing. Sir, overall survival is one thing, but the point is living without disease is also very, very
Perfect.
important.
So I'm not
And
taking
also,
anything out of the trial.
let us say something, somebody gets a brain met, somebody has to get radiation, somebody gets leptomeningeal disease, after that will get radiation. So I think that is also something which is very important.
Perfect.
Even if let's say at 5 years or 6 years time, patients are not living, survival is equal, I would still like to live without disease, although the toxicity also has to be managed properly.
Okay. So the last point which I wanted to make, although there is a criticism about the post-treatment and there was a very lesser number of patients, and this criticism will be there in lot of studies, but the point here is what Ullas made, you would like to patients to live without disease. So that's more important. If then the events can be sometimes lethal, and many times patient cannot be cannot survive long after brain mets or something else. So let's now come down to the topic. Suman, you have all of us have gone through this data set, the new Adora, and this has been published in the JCO 7, 8 days, 10 days back. We have a full publication to this trial also. So anything as a criticism for this, or anything to be for people who have not gone through much of it? This is a patient who would have taken only stage 2 and 3 and 3 till 3B. 1B were not taken in this. Point number 1. Point number 2, they just took the DEL 19 DEL and the L858R. So two most common mutations were taken, and these patients were randomized 1:1:1 way, and into a osimertinib single agent versus osimertinib plus chemotherapy, and versus placebo plus chemotherapy. And the arm of chemotherapy were double blinded. The osimertinib was open label. So this is a trial where you have a double blinded and open, and this arm was A and C were double blinded. The arm B was open because you didn't have to give an injection. So this is something that was there. Then the patient was operated after 9 weeks of neoadjuvant treatment. So remember, it's only a 9 weeks. And then the patient after surgery was taken up for adjuvant treatment. As per the Adora, they were promoted to get osimertinib on adjuvant setting for 3 years. So, Suman, anything which you feel is not correct, because this looks a perfect trial to me on the first look.
No, I think at the first go, it looks as a proper trial itself. Maybe MPR is probably not some of the endpoints I would have taken. I think that was a weird endpoint. And in this
Weird.
trial,
Yeah, they
I
have
mean,
a
because
justification in the paper for that. They have given a justification, but you feel it is not that powerful for us to change practice.
no, because you can't. So are they trying to say that if you get an MPR that translates into a PFS, or are you trying to say that MPR is equivalent to PCR? I mean, what exactly they're trying to say?
There is a data set from NSCLC, at least from the, not this subset of patients actually. There is a few small data set from the EGFR positive subset also, but the major data set comes from what we have done, that MPR once we achieve, these are led to a event-free survival and a probable OS survival. That data set is there for most of the lung cancer, non-small cell lung cancer.
No, but then what is your percentage of MPR?
Yeah, we'll come to that.
Yes.
Akhil, you spoke about MPR, which Suman has spoken about. Do you feel this is the most appropriate endpoint for a neoadjuvant data set?
So this
Or it
endpoint,
was a low-hanging fruit which AZ just took it?
yeah, this seems because actually, sir, EFS will take a significant amount of time to mature, considering all patients, more than 90% patients receive Adora regimen in adjuvant setting. So we knew EFS data will take a longer time to mature. That is why AZ chose this endpoint. This is the only problem. But yes, this seems to be a strong endpoint. But problem is that how much it is relating to EFS, we are not very sure, and it's very doubtful they will get even approvals based on MPR data.
Okay.
That is what I understood.
Ullas, were you surprised when you saw that event-free survival was not a co-primary endpoint?
Very surprised, sir. In fact, just to recap, there was a trial. I mean, you're right that there was a meta-analysis which said in NACLC MPR correlates with OS, but that data was with the chemotherapy.
Yeah.
As I have been telling, chemotherapy is different from immunotherapy, is different from target therapies. So you just cannot. I mean, we are lowering the from OS. We came down to PCR as surrogate marker. From PCR, we are going to MPR as surrogate marker. So a very low hanging fruit. AZ was smart to do, but not a very academic, scientific, robust endpoint. The second criticism which I have on this trial was osimertinib as a monotherapy.
Mm-hmm.
Now, I'm sure you will show the data in which, in fact, osimertinib has done more better than OC plus chemo.
At least similar. At least similar.
At least
Let's-
barabar. At least barabar.
Yeah, no, sir. PCR is better with osimertinib actually.
I understand. Numerically better. Yeah.
Numerically. But the point is, if you look at all the previous trials, it has the MPR rates and PCR rates have been too low. So that is my other second criticism, that OC may not have been the right arm, but fair enough. But MPR, yes.
Fair enough. The results show what it is. That's what it is. And that if you look at the publication, look at the interpretation. Actually, this interpretation coming up that probably do we need chemotherapy in this new adjuvant setting? We'll discuss that in a minute. So Ullas pointed out one important thing, and Akhil and Suman also. The MPR alone as a primary endpoint looks a little low-hanging fruit just for a approval setting. That was what it was. And second thing, we would expect if a company like AZ and a powerful company to have that event-free survival as a co-primary, and you never see overall survival. So basically, this trial was not designed statistically powered enough to look at OS. So guys, you would never want to see OS. Although we may go on saying that OS nahi hai, OS nahi hai, this trial did not have any endpoint as OS. So that people should remember. On the statistics quickly, that they wanted to see 20% delta between the chemotherapy alone versus the both the arms. But the important thing, what Ullas pointed out, but it is written in the manuscript, is they expected that the MPR in the chemotherapy arm alone would be 20%, which was a very, very low 4 to 5%. So if you look at it, the expectations of the MPR in the chemotherapy alone was below what was their expectation, but the delta of 20% somehow was met. That is how the primary endpoint was met. So with that, this is the data set. If you look at it, 2-3 things that comes out is chemo plus OC versus OC alone. It looks similar. Numerically, there might be a little higher for OC alone, which Ullas was pointing out. But Akhil, I think we all will say that OC plus chemo or OC alone is similar in all aspects. Is it a fair statement?
Yes, I completely agree.
Okay. Even people who want to go for surgery and artery resection also look similar for both these arms. Ullas, quick.
Yeah, sir. I was just making a small stupid comment.
Okay. So again, if you look at the MPR, 26% OC plus chemotherapy versus OC alone, 25%, and that's with 9 weeks alone, versus 2% only for chemotherapy. Suman, your comments first, and then Ullas on this particular endpoint graph.
This clearly, at least this graph show that OC does better. Whether you give chemo without chemo, OC definitely is probably the way to go forward in this sort of a population. And I think they also had definitely nodal downstaging also, which was significant with the OC. Any arm that had OC versus the chemotherapy. So probably chemo alone is out in such a population, at least as per this data. Whatever.
Ullas, were you surprised by seeing that OC alone is as good as OC plus chemo?
Absolutely, yes, sir. Especially in the light of the old, all the new NORA and all those studies that the osimertinib was part of. Definitely, osimertinib alone has overperformed, and only chemo has underperformed. My take-home message from here is, if I ever want to give neoadjuvant chemotherapy in a patient of EGFR mutant NSCLC, I like to incorporate osimertinib. I am not letting go of chemotherapy.
So neoadjuvant chemotherapy alone is out. That's
alone is out, yes. So I might just give only osimertinib, get the patient to surgery, give 4 cycles adjuvant chemo, and then do ADAURA. Or I might just do neoadjuvant chemo and OC, and then go ahead with ADAURA. I want to incorporate osimertinib.
Okay, I got it. So basically, chemo alone is out.
Go of chemotherapy.
But still, you would not let go of chemotherapy.
No.
Lot of people were surprised with this chemotherapy plus OC. Amol, you want to come in and say something on this MPR? No, he's only smiling.
No comments from my side.
Okay. Akhil, quickly.
Yes.
Quickly, any comments on the MPR? Were you also surprised?
Somewhat yes, because everyone expects chemo plus OC to give better responses. But yes, what we understand, it is the long term, the resistance mutations when they appear, there it is chemotherapy is acting and reducing the chances of resistance, but not within 9 weeks the resistance mutations will crop up. That is the point.
Second, last point which I wanted to point it out, only 80% of these patients receive adjuvant osimertinib across.
Now you're running out of time.
No, I started 5 to 7 minutes late. I'll take my full time. So if you look at it,
sir, I came late. You take from my
so if you look at it, 80% only receive adjuvant osimertinib, although they had access to the drug by the company. That is something people will ask when
I
this
think
trial
it was
is
more than 90%, no? जो मैंने
80%.
पढ़ा था.
80%. So, and this
So,
is something.
neoadjuvant part, 91% of adjuvant OC across.
10% लोग
So
तो
if you
PD
look
पे हो
at
गए ना.
from the number who were randomized, the persons who received, and it comes down to around 82%, not a 90%.
सर वो जिनका सर्जरी नहीं हो पाया वो अलग है.
They allowed
वो भी included हो गए
osimertinib
उसमें.
even to those patients who were not operated. So with that data is there actually, and the consort is very busy. So you can go back to publication and check what I have told. So very quickly, because Amol has come in and he's bullying us. So now what has come up, the conclusion is what I like to say. All the discussants have told today, this is a very attractive option, but they would not change practice based on this new adjuvant data set osimertinib. The surprise was the very non-different MPR between the osimertinib alone and OC plus chemotherapy. Even I was little taken back by this. And the very poor MPR with chemotherapy. So it tells us that if you are EGFR positive, try not to depend on chemotherapy a lot. So that thought is now coming in. And the last important thing is this trial was not designed to look at OS. Don't look at OS in the future. When the event-free survival matures, it's only 15% maturity. And the EFS, Akhil, if the EFS holds on and meets its criteria of maturity and you feel that, okay, it's positive, will you change practice?
Yes, why not? If EFS is positive despite giving adjuvant osimertinib in around 90% patients, it makes sense to shift.
So basically, we have to wait for the mature EFS. Ullas, any last comments on this?
Yeah, there is an accompanying editorial by Suresh Ramalingam with this in the JCO. Please go and read that. Fantastic art. Fantastic.
So
we discussed in our journal club only that editorial. We didn't discuss the paper today.
Yes, I mean that editorial is fantastic.
Yes.
Alniot study, again I put this up because this is the same type of concept which is there, except for the alectinib is given for 8 weeks, 2 cycles instead of the 9 weeks. And this concept goes that alectinib is given for the patients who are stage 3. Again, subtle differences. They did not include stage 2. They only include stage 3. And this is a very small trial of 33 patients. Ullas, of these 33 patients, what do you feel? This data set looks good enough for you? As good as the Neo Adora?
Sir, 33 patients, I mean, the number is too small, although they had stage 3 patients only and the MPR rate was there. But again, the fact here is that an ALK is different from EGFR. If somebody doesn't really want chemotherapy, I'll be slightly okay. I will not push
what is the harm in giving a neoadjuvant for a patient who's stage 3, 8 weeks of alectinib, and if you can achieve an MPR of around 40% and it meets it meet its primary endpoint?
No harm, sir. That's what I'm telling you, sir. No harm. Okay. I am telling you, if a patient is not really willing for anything very aggressive, I'll be absolutely okay in giving him.
And then operate after 2 months.
Yes, sir.
Suman, any last words on this?
Data is very small, sir. So I think
it looks very similar to Neo Adora. Okay.
Yeah, but ALK is somewhat we are more confident about ALK. मुझे हमें पता है कि ALK में तो देना ही है जितनी जल्दी दे सको.
That I agree.
That I agree, but
would you give it to in your practice, Akhil?
Yes, if patient is feasible for alectinib and also in adjuvant, I will be happy to utilize in neoadjuvant setting, even based on phase 2 data, small data, if feasible.
Okay. So anything both of you or 3 of you want to say before I end for the neoadjuvant and adjuvant on alectinib space and the EGFR space?
Sir, I think my point is whether to give EGFR or ALK in adjuvant, neoadjuvant doesn't depend on ALK or EGFR. It depends upon the operability and the resectability for the surgeon.
Perfect.
Let's do this. If the patient
for a resectable lung cancer patients.
For the resectable lung cancer patient, I'll do surgery and then give him Alina.
Okay. At this point, that is your standard of care, which is the first conclusion. Adjuvant, osimertinib, alectinib are acceptable standard of care as on date.
Correct.
The neoadjuvant approach looks attractive.
And when I use neoadjuvant for the reason of whatever, then I will definitely want to include osimertinib into the this thing into the armamentarium, and maybe alectinib we can use over there. That's what I want to say. Only
Okay.
chemotherapy is not good enough. That's
Okay.
what I will say.
Suman, any last word?
The neoadjuvant OC for sure. Alectinib, well, if Dr. Ullas says do it, I'll do it. But adjuvant, don't know. Definitely.
Okay. Akhil, last
Dr. Ullas is brilliant people.
Akhil, last words.
Dr. Ullas is our
Please
leader.
don't bully us. Akhil, last word.
Yes, sir. So
Yes.
definitely all adjuvant data are already very, very encouraging, and we like to utilize adjuvant as much as possible. The standard of care presently sticks to the adjuvant. We'll try to stick to the standard as much as possible. There might be some areas where we can consider utilizing neoadjuvant approach, but presently neoadjuvant approach is not for all. That is the
So
take.
I would also like to end with the same thing what my co-discussant has spoken. Adjuvant is the way, and we have robust data and longer follow for that. The new adjuvant, the only best thing is it is at least with the data set that's coming out, it's not detrimental, it's not harming the patient. And the best thing is we are giving it for a short 8 to 9 weeks. That's point number 2. It's not given for a long time. Ullas pointed out made a very important thing which we discussed: no chemotherapy. That gives us a more concept. The chemotherapy in the if thinking of neoadjuvant, add the TKI. You may give chemo, may not, but the TKI is the main thing that's going to make you achieve those MPRs. And you need longer follow-up. Please do not start. Please. Suman told she will practice, but I think I'm here with the Ullas and Akhil here. I do it for
more
1
Buddha
2.
ones.
Yeah.
More Buddha ones.
The young ones may go on to the osimertinib quickly, but I think for us, we have burnt our fingers a lot of times. We like to wait for the EFS to mature, and that is actually what the JCO conclusion was all about. So with that, I'd like to stop here, and I will thank the organizers, thank all my co-discussants, and if you have missed anything, please put it on the chat, and we will love to discuss with you. Thank you.
Adjuvant zilpretinib trial is started, so it
Yeah.
might be useful.
So anything that is not there for lung cancer, call Ullas and Akhil for trials, and they will enroll your patients into the trials.
That we will do, sir.
Thank you. Thank you so much.
Thank you.
Thank you. Thank you, Dr. Sahu.
Thank you,
Bye.
Dr. Thank
Thank
you.
you, sir. Thank you.
Thank you,
So
Dr.
I'm 9
Sahu.
minutes late.
Okay, Dr. Amol is the next speaker, and as he has already said, we are late. Dr. Amol, you can take the floor with your panelists. Dr. Sahu. Hello?
Yes, we
Hello.
can hear
Yeah,
you,
I'm
sir. Yeah,
audible.
we can.
Dr.
Yeah, you can hear
Vamshi.
me? Sorry,
Yes.
I'm not getting the feedback here whether you can hear me. Okay, to Dr. Amol, over to you. And you can please call invite your panelists. There's also an unanswered question in the Q&A which somebody can take. Or else you can address it in your panel.
So first, let me thank organizers for inviting me. I don't like Zoom meetings, and I don't like hopping from one Zoom meeting to another, which exactly right now I'm doing. So I already shared my slides with the organizers. So please, can organizers share my slides so that the onus of slides not visible doesn't lie on me. That is the exact reason I have shared the slides. So let me invite my panelists. And we have very star-studded panelists. We have Dr. Venkat, Dr. Prabhat, and of course, the not geriatric oncologist, the young and dynamic Dr. Sahu. Dr. Sahu is there, right? Yes. Yes, Dr. Sahu is there. So we will be discussing on the on non-oncogen addicted perioperative management of early stage non-small cell lung cancer. And next slide. I have no conflict of interest. Next slide. So we are discussing oncogen non-addicted resectable non-small cell lung cancer, medically fit patients. So let me start with Dr. Prabhat. For whom you will not give NSAT IO or perioperative IO in this particular subset. Resectable, non-oncogen addicted, and medically fit.
Stage 1.
To whom you will not give?
Stage 1A, I will not give.
1A, you will not give?
Yes.
So for 1B, you will give perioperative IO?
Stage 1B, maybe, and stage 2, 3, yes.
So 1B, you will give perioperative IO.
That's what I'm saying.
Based on which trial?
1A, I will never give.
Based upon which
1B,
trial?
I may give.
1A, you will never give. I agree.
1B, I may give.
So my question
2 and
is,
3, I will definitely give.
so 1B, based upon which trial you are giving perioperative IO?
So
1B.
I'm not saying perioperative, I'm saying preoperative predominantly. So most of the
So 1B, you will give only. So let me ask Dr. Venkat, what's your thought? To whom you will not give? I agree. 1A you will not give. For 1B, Dr. Venkat is there. Sorry.
Yeah, I'm there. Probably I will err with Prabhat, may or may not, depending on what the patient wants. The data is not too hard. Definitely for 2 and 3.
Okay.
1B, I will be on the fence. Yeah.
And Dr. Sahu,
What Prabhat and Venkat has told, I totally
you will give.
agree with him.
Will you give perioperative IO? Will you give perioperative IO
Perioperative
for
1B, no. Preoperative, there is the checkmate which we will discuss. But I will also be little skeptical. I had a debate with Prabhat at 2 years back, and I have been very clear about it. For the PDL1 negative, I'll be skeptical to give a.
We'll come to that. We will come to that.
No, you asked me where I will not.
We will come to that. We are only talking about the stage.
Okay, you didn't
Okay,
tell
so,
that. Not whom you will
let
not
us-
give, you asked.
Okay, fine. So PDL1 negative we'll definitely discuss. But from the stage point of view, 1A, no. 1B, there is only one trial, that is Checkmate 816, that is preoperative. There is no data for perioperative IO for 1B. All perioperative IO trials are stage 2 onwards. So next slide. Yeah, so this is a very beautiful slide which is made by a Japanese medical oncologist, not made by me. It gives all the trials which are there in this particular space, and one can see the inclusion criteria very clearly. Only Checkmate 816 as 1B, rest are 2 onwards. So there is no perioperative trial for 1B. So that is one point which is important. And of course, for 1B, we will see the data as we discuss. Can we have the next slide? So these are what we call as the money slides. If someone, students are there, they can take a screenshot of this. This gives all the trials, all data as of June 2025, including the updated OS and EFS, everything. So Dr. Sahu, any idea which of these 2 trials have got positive OS? Because in non-small cell lung cancer, unlike your discussion, OS do matter. So we will discussing only those trials which have got OS and declared positive OS.
We had a Checkmate 816 release the OS data. We have also the Pembro data, which is a positive at the 4-year OS time point. So these are the two, and even the perioperative Nivo data is also positive.
So perioperative new data is positive for OS, Dr. Sahu? You're talking about which particular trial? NeoTorch is positive for OS?
No.
Dr. Prabhat, you agree?
Not NeoTorch.
So which one? Which perioperative? Checkmate 77T is positive for OS?
Think.
Are you sure?
I think.
You think?
Yeah, I'm not sure.
We
But
don't have OS data yet. I mean, to the best of my knowledge, we don't have for 770. We don't have OS data yet.
770 में सर अभी आई थिंक फॉलोअप डेटा मैच्योर जो नहीं आया था उसमें नहीं था पॉजिटिव अभी तक
70 का डेटा अवेलेबल
नहीं. Can I have the next slide? Can I have the next slide? So to the best of my knowledge, there are only 2 trials which have got OS data declared and is positive. And I assume Dr. Vishwas, who is presenting the Checkmate 770, will agree that there is no OS data declared for that. So as of now, there are only 2 trials, Checkmate 816 and Keynote 671. So our further discussion will stick to only these 2 trials because in non-small cell lung cancer, OS matters. So to start with Checkmate 816, this is the trial design. And everybody knows that. We will go to the next slide. Can I have the next slide? Yes, the statistical plan. So Dr. Sahu likes the statistics, and he has taken Dr. Sudhi Gupta's wonderful lecture in his meeting. And since then, he always says Dr. Amol is not discussing statistics. So whenever Dr. Sahu is there, we'll discuss statistics. So PCR and EFS were the primary endpoints, and there is a hierarchical system. That means if the PCR and EF is positive, then they will test for the OS. Dr. Sao, are you happy with this particular statistical plan?
I think it is fair enough. They had a hierarchical. If PCR is positive, they'll go for EFS. If EF is positive, they'll go for OS.
OS was not primary endpoint. Are you happy with that? In a non-small cell lung cancer
It's
trial,
fair.
this is not early breast
This is a
cancer
fair
trial.
statistical way of. This is a fair statistical design.
What if I tell you other trial has OS as primary endpoint, and will you be more happy with that data?
No, I think this trial, I'm not looking at the primary or secondary. I think Amol, what I learned, I know about statistics is this trial was powered to look at OS, and there was a hierarchical system. If PathCR did was positive, is significant, then they looked at EFS. And if EFS was significant, then they looked at OS. And that is a fair way of looking at this. It is not that something was insignificant and suddenly they come up with the other data. So I think this is a fair way of looking at
But
it.
shouldn't okay. So Dr. Venkat, do you agree that OS should be the primary endpoint in the non-small cell lung cancer trial, or it is okay to be secondary endpoint?
To be frank, I am
Non-small cell lung cancer, our survival is very limited.
for me, OS should be the primary endpoint because, but the pharma companies always do the statistical jugglery. But as long as you do it before the trial and not post hoc, I'm okay with it because then they've pre-planned it and then they powered the trial adequately.
Yeah.
But I personally am not a big fan of the hierarchical analysis. I would power the trial to do an OS analysis.
Can I have the next slide based on the same point? So I had shown here the comparison. Next slide, please. Comparison of the two trials which have got OS, the statistical plan comparison. Can I have the next slide, please? Yes. So this is the statistical plan comparison of Keynote 671 and Checkmate 816. The two trials have got OS. And please look at the Keynote 671 has OS as primary endpoint, EFS and OS, where Checkmate 816 went for EFS and PCR. Then, of course, the hierarchical system was there in Checkmate 816. Look at the amount of alpha that was allocated to PCR, 0.01. And of course, the overall conclusion is that the design strength-wise, the Keynote 671 is a stronger survival-based design, more robust, while Checkmate 816 is a simpler design, faster early endpoint, that is PCR. So Dr. Prabhat, what is your opinion? You have two trials. One has OS as primary endpoint. Both have OS positive data. But when you compare, will you go in favor of Keynote 671 because of a better statistical design?
So, I mean, I'm not going into those details. Both the trials had totally different treatment strategy. One is preoperative only, which is like give you a kind of an early idea whether giving neoadjuvant immune checkpoint inhibitor combined with chemotherapy have some impact on disease outcomes. So whether it is PathCR, and that's what they expected, that PathCR would be higher, and they would get the things early into the clinical practice. On the other hand, it looks at like the Keynote 671 looked at more holistic kind of a treatment plan where you give preoperative treatment and then you give post-operative treatment as well, which they expected that would have an impact on long-term survival. So these are two different strategies. To me, if I look at it from my clinical practice point of view, an impressive PathCR on a significant improvement in event-free survival is a reasonably good endpoint because you have to look at it when we are after overall survival, that should be better with any new treatment. That all depends what second line treatment you have. I mean, all of us who are treating non-small cell lung cancer, we know when these patients recur, when they're metastatic, really, I mean, how many patients are really cured and what's the survival after that? So you don't really have whatever you have in the first line in the curative setting is probably the best way. So to getting the drug early into the clinical practice, I think event-free survival is a reasonable endpoint.
Yeah.
And if I'm thinking of giving, I mean, due to some or the other reason, if I'm just thinking of giving 3 cycles of neoadjuvant treatment, be it a financial reason or a logistic reason, I think that's kind of a bare minimum, which every patient who is being planned for neoadjuvant treatment should get. So I'm not, my approach is a little bit more practical. I'm not comparing two drugs, nivolumab versus pembrolizumab, the way they designed their trial. I mean, these are two different trials. They looked at these two different strategies.
So I think my slides are still visible because my internet connection is not stable. So Dr. Sahu, yeah, they are visible. So they're not visible to me, sorry. So can the organizer look into this? So Dr. Sahu, what's your take on this? We have two positive trials. One trial is included OS and showed OS benefit. Other trial has not included OS as primary endpoint. When you are going for statistical point of view, which
Amol,
one you will...
I got a question. I totally am with what Prabhat spoke, and I just want to tell they also took a gamble. If let's say the EFS would have been negative, they would not have gone on that thing to OS at all. So it is a thing that they had the statistics, they had the data set, and had allocated the power, the alpha already before. And as per the statistical plan, they went on to prove a PATCR, event-free survival, and then they went on to prove the OS. So let's give it to them. And you have to agree that they did not do anything mid-trial. If they had done that to make a trial positive, I would have given what Prabhat told that just 3 cycles, the PATCR would have been the primary endpoint. But they were looking at a different
what about there is one more point of double blind versus open label. Does it make a difference to you when you're choosing the data, or it's okay? One was double blind, one was open label.
Okay, it does make a difference, but most important is many times what you look at is double blinded would be a better way of doing clinical trials. That I totally agree, but it cannot be as simple as that. Many times, who are unblinded is an important question. Many times we need to ask. So that is something that, but yes, I agree. Double blinded is a better way of looking at it.
So, Dr. Amol,
so slowly we are agreeing that. Yeah, please.
Dr. Amol, I would, for your this question regarding blinding, because the endpoint here is not observer dependent, which can bias your assessment. One of the endpoint is PATCR. If it is there, it is there. So it would not have such a strong bias introduced if you are not blinding these patients. I mean, if you blind, it's wonderful. It's if you are more purist in statistical approach, it's wonderful if you can do that. But if you haven't done anything really bad. And same thing in regarding your question from the statistical point of view. I agree with you that for 816 is a relatively weaker statistical design. If you talk in purist term, but it is still acceptable from clinical standpoint of view.
They're not able to hear you.
Statistical plan also. Okay. Sorry.
Amol, can you switch off a video, Amol? We are not able to hear you actually.
Am I audible now?
Hello.
I think Dr. Amol sir left the webinar.
No, that cannot happen. You have to rephrase your word. Amol can never leave.
Dr. Sahu can take over as a moderator and he will be moderatorless.
Ulas, take over. Hey, the आवाज
Okay. I'm very sorry for the very bad internet service. We are having rain in Powai. So, are my slides again visible?
Who is in power in Maharashtra?
Yeah, I know that. We will get back to you next time. We cannot control the rain. Are my slides visible? It's not visible to me.
Yeah. You are on the
somebody sharing
OS slide.
Yeah,
Fantastic. So now that we are moving on, we have final OS declared for neoadjuvant Nivo plus chemo versus chemo. Next slide. And everybody is happy with the 10% difference. Next slide. Now, this is the point that we wanted to discuss. At the PD-L1 expression, and if you see for the hazard ratios for the PD-L1 less than 1%, the confidence interval is going up to 1.41. So this one should remember. Now, next slide. So then the question comes, which Dr. Sahu has raised, and that will ask to everybody, starting from Dr. Prabhat, are you comfortable using this particular strategy in a PD-L1 negative patients when your OS hazard ratios are going up to 1.41 in confidence interval? Or you will not use it for PD-L1 negative, or you will use it irrespective of the hazard ratio confidence interval? Dr. Prabhat?
So as of today, we are not differentiating patients receiving neoadjuvant chemoimmunotherapy based on PD-L1. We are combining chemotherapy with nivolumab with the chemotherapy. And even for EFS, when it was initially reported, these signals were there that the magnitude of difference is much better for patients who are PD-L1 positive as compared to PD-L1 negative. But again, this kind of a
here the
subgroup
confidence
analysis,
interval is going to
when you were
1.41.
talking about Amol, when you were talking about the statistical consideration, so this trial is again not powered to really see. This can only give you an idea that probably it doesn't benefit patients who are PD-L1 negative to that magnitude.
So you are saying that it is not powered, it is not great magnitude, but still you will give it.
Oh yes, I will give it.
Dr. Venkat, what's your opinion? Will you use it in PD-L1 negative patient, this particular strategy of only neoadjuvant, or you will like to see some better data of perioperative trial in which maybe the results are better?
The common sense tells me that I won't give it, but I do agree with Prabhat that it's a subgroup analysis hypothesis generating, but the curves just kiss each other and overlap each other. I won't give it to my PD-L1 negative patients.
Dr. Sahu, will you give it neoadjuvant 3 cycles
I would discuss it. I'm not very enthusiastic for two reasons. Prabhat rightly pointed out it's not statistically powered for that everyone agrees. But look at the numbers. If you can put back, they're really equal, nearly equal number, 40-60%. The second point which I'm pointing out, which people have to remember, is that if you look across trials and look at even the Pembro trial, and look at the subset analysis of less than one and more than one.
I'm going to show the Pembro data.
So I was coming to an important point, and if all the data are pointing towards a similar thing across all immune checkpoints, I would be a little skeptical, especially for the patient with a middle income group with not so deep pockets. So that is my take. But yes, I totally take it that if someone does it, this trial was not designed for that. But the thing that I'm making is it is being seen across trials and across immune checkpoints. And if one similar thing is being looked into and same data is coming, if that PD-L1 negative is not benefiting that much, I'll be a little skeptical. But yes, nothing wrong in doing it.
Can I have the next slide? We'll show the Pembro data. Can I have the next slide? So this is the Keynote 671 oral OS in key subgroups. And if you see, of course, in PD-L1 negative, if you can see in this particular, I think it should be here. Yeah, it is there. And it is, of course, not good. They have very strategically not given the hazard ratio only or the confidence intervals, but everybody can see that it is crossing the midline. So I agree with Dr. Sahu that it is across the immunotherapy agents that for PD-L1 less than 1%, the benefit magnitude is not much. And especially for earlier stage, like stage 2, one should discuss with our patients whether they really wanted to go for this or not. So that is the point for PD-L1 negative. Next slide. Now let us coming by the baseline stage. And again, if you see for this particular trial, checkmate 816, stage 1B and 2, the hazard ratio confidence interval is going up to 1.35. So this is the not exactly, suppose this would have been oral SERD, Dr. Sahu and Dr. Vamshi would have said, no, it is going up to 1.35, we cannot give. But now it is because nivolumab only 3 cycles, so everybody is saying, okay, fine, I will discuss. But next slide. So are we happy with the confidence interval OS for stage 1B to 2? Dr. Sahu? 1.35 is the upper limit of confidence interval.
The hazards is quite different from what we spoke of PD-L1 negative and positive. Yes, stage 3 does benefit more, and that is I've seen across trials, but I will still give it to stage 2 all of my patients till a trial is powered to look into this and tells us it is a negative trial.
So basically, we are decided that we'll ignore the confidence intervals and all those things in non-small cell lung cancer early stage trials.
No, we are not telling that, Amol. We are telling was the trial powered to answer that question. That's very important. I think Prabhat can take it, and if Prabhat has a different opinion, he can just state it.
So
Yeah,
here,
so
I
Dr.
mean,
Prabhat,
here very strategically, Dr. Amol, what we are discussing that we have clubbed 1B and 2. So if you segregate,
yes.
if you segregate them again,
it will be on the reverse for 1B.
So yeah, the things would be a little more different. But again, that question of the power of the analysis and all those things come. If you look at that subgroup analysis, obviously you will not talk about those subgroups which are very easy to see. You haven't talked about that. Like it's not benefiting with a person age more than 65. Would you not give a person who is more than age 65? It's not benefiting a person who is a non-smoker. Would you not really give, would you differentiate based on the smoking history? So these are all, I mean, thought-provoking idea. And we, as a clinician, we all understand that, stage 1B, probably the magnitude of benefit is going to be too small to be statistically very significant. You need a very large trial to demonstrate a statistically significant difference in a stage 1B. And stage 2 as well. And none of the trial would adequately be the power to answer that question. I'm not expecting any future trial which would answer your question. I mean, these treatment strategies, when we discuss, even today, if you ask me whether you give chemotherapy in a stage 1B, I mean, again, these the magic number of 4 centimeter came from that statistical analysis of the pooled data. Right. So
I agree.
So all these kind of fine dissections are possible when probably you are pooling all similar kind of trial and trying to get these answers. We know as a clinician that patients who are stage 2 onwards, they require a systemic treatment. If you give it pre-operatively, their tolerance is better. You get to know the pathological response. Based on both the trials you're going to discuss, I would say that patients who do not achieve pathological complete response, probably these are the ones who would require some sort of an adjuvant treatment, which can be a continuation of the Checkmate 7/7T kind of a format or a perioperative Pembro format. But patients who have achieved a complete pathological response, probably they don't benefit that much with the continued treatment. The delta would be lesser. But again, you will never have another trial to answer your question.
So let me come to that. Your point is well taken, but let us understand the smoking history or age, there were not pre-specified subgroups. The stage was pre-specified. So this particular analysis is a pre-specified analysis done by them only. So when you compare with the other subgroups and the stage, there is a difference because this was pre-specified. They have said that they will do that before the trial. So now I got your point that we cannot have one more trial. We cannot have a different trial saying that what is the exact magnitude benefit. So yes, we have to discuss that with the patients, that the magnitude of benefit for PD-L1 negative is less, for stage 2 is less, and then let patient take a call. But this was a pre-specified analysis, and that is why it is I had shown that. So moving on, Dr. Venkat, you have another thought?
Yeah,
In spite of this,
why are you fixated on the hazard ratio? Why don't you go on the absolute survival benefit, which is much more meaningful, because you might have a small absolute benefit with a large hazard ratio. So I think the absolute benefit in survival is around 4%. If I'm right?
Absolute benefit. Okay, can you go back to the account?
Yeah.
Can you go back to the previous slide, please? Can you have the previous slide? Yeah. So no, previous slide. This is the next slide. Previous slide. The stage wise.
One slide back.
One slide back.
Yeah.
That's 5.
Yeah. So if you see here,
yeah.
So it is around 5% difference.
Which is good in terms like you are happy with 3%, 4% for breast cancer. I think 5% with widely separated curves. Why are you still in doubt?
So okay, I will show you the subsequent slides. Dr. Venkat is happy with 5%. I will show you some other slides also. So, move on. Next slide, please. Next slide. Now, this is exploratory analysis OS by PCR status. And I want everyone to look at, of course, the down arm when the PCR was not achieved. So, Nivo plus chemo, 56%, and chemo is for 54%, only 2% difference. So now, Dr. Venkat, what's your thought? Now the difference has got to 2% in patients who have not received PCR, achieved PCR, and the difference between Neo plus chemo versus chemo alone is only 2%. So what's your thoughts on this now?
So Dr. Amol, this is after only you give Neo. You don't have a biomarker which is going to predict which patient is going to achieve PCR versus not giving PCR. This is like your osteosarcoma. So
if my chemo is giving me 54% and my addition of IO is getting me 56%, for a bad biology disease, yes. For a good biology disease, it is making a difference.
We currently don't know who's going to be the 95% and who's going to be the 95% and who's going to be the 50%.
Dr. Amol sir, sorry to interrupt, but you have 3 minutes to conclude, sir.
So there is no way to find out who's going to be the no PCR and PCR. Otherwise, it'll be easy. Life would be easy. So you have to give to everybody.
Another interesting point here is that actually those who have received chemo and have achieved PCR, they have 100% survival versus those who have got Neo plus chemo 95%. So it is not that the chemo should be discarded. Yeah, number is small. I agree. Number is small, but it is not that the chemo in a good biology, if it works, probably it will give you a better results than the Neo plus chemo also, as per at least the data. Next slide, please. We are running out of the time, so we will run with the slides. This is again the same PCR status. Next. So, okay, one quick word. What we'll do if you don't get PCR after Neo plus chemo? Dr. Prabhat, will you do ctDNA or will you, what will you do?
So, patients who do not achieve a complete pathological response, they have relatively poorer outcome. They certainly require some sort of continued treatment, and probably to these patients, extrapolating again, although you have not shown those slides, if you really, the 671 trial, the maximum difference, because that's the point you were highlighting, then patients who do not achieve a PAT-CR,
I have
so
the
difference between these two arms narrowed down. And in the Pembro arm, this difference is much more wider. So probably this difference is much more wider, not because of the difference in the drug, but because of the difference in the continued treatment. So to best of my understanding, I don't have any better data to discuss this, but that's the best thing we have, these kind of segregations of subgroups. And probably these are the patients who really benefit with continued treatment. So if I have started somebody on Nivo plus chemo and patient has not achieved PAT-CR, I would give probably continued nivolumab for at least 6 months to 1 year. And that's what we have data for. I will not do ctDNA at the moment. We know that ctDNA has a prognostic value, but whether by changing treatment with ctDNA would overcome that negative factor, we do not have that data yet. So I will not use ctDNA as a surrogate biomarker as of today.
Can I have the next slide, please? Next slide. DNA, we are prognostic, we are doing it. Next slide. This is the data that Prabhat was saying, that one previous slide. One slide back, please. Yeah, this is the data that Prabhat was saying, that continuation of adjuvant is the one that is having a clear separation of patients who have not received PCR. This is from Keynote 671. So I agree that probably a perioperative strategy is much better than an only neoadjuvant strategy. So coming to my last slide, one quick question to all the panelists, starting from Dr. Sahu. Will you prefer checkmate 816 or Keynote 671? Money is not an issue. Dr. Sahu?
I think I'll start off with 816. The Kaplan-Meier, at least for the OS and EFS, looks similar. And if you look at it, the data points across trials at 4 years, the 3 years, it looks right bang on with 1 or 2% difference. But yes, as was pointed out, if it doesn't achieve a path CR, you have the option of continuing the immunotherapy as a perioperative or the neoadjuvant.
So you will start at 816 and you will go to 770 if you don't get the patch here. That's what you're saying.
Yeah.
So you will do jump from one trial to another.
No,
What about
I'm
Dr.
not
Venkat? Will
jumping from
prefer
it. It's
816
not
or
that it is not how you look at it.
so why not start from keynote 671 for everybody? If the money is not an issue.
My point here is I achieve a path CR in a quarter of patients. These patients I can get away with 3 cycles alone. So and it makes economical sense to me. And if I look at these Pembro data and look at the checkmate data which we have discussed and look at the Kaplan-Meier with that fault of looking across trials, they look similar in all oncological outcomes. So based on that, I will do that. And because it is not a trial, you have the option of adding something which Prabhat spoke for the patients specifically who did not achieve a path CR.
Okay, Dr. Venkat, will prefer 671 or 816? Money is not an issue.
Money is not an issue. I'd prefer 671. Generally, I'm not a fan of cross trial changes. So 671.
Okay. Dr. Prabhat?
So usually what I
Which one will prefer?
Yeah, so usually I practice majority of the time is 816 because when money is always a concern for us. And when you do these kind of analysis, the one way of looking at is really number needed to treat to save one life. To me, if we are following 671 approach to everyone, there is a reasonable number of patients probably who are over-treated. And if you follow just 816 for everyone, there is a good number of patients who would be undertreated. So it would be a good balance. Regarding jumping in practice from one trial to another trial, when we treat a patient, we are not doing a trial.
Yeah.
We are extrapolating that information
Yes.
to our clinical practice to the best benefit of our patients. So whichever strategy suits to our patient best, I would follow that.
Can I ask this
So let me go to the
one
last slide.
question? Amol,
Let me,
just one
Dr. Sao, Dr. Sao,
Do you have a
let me give the conclusion
post-treatment,
slide, please.
one very relevant question. Do you have a post-progression slide for 816?
Post-progression slide for 816 is not there. They have
Okay,
not given
so
that data.
I'll ask Prabhat, Venkat and Ullas is there, even Akhil is there, you are there. I was surprised they had EGFR ALK negative. And when I looked at the post-progression treatment, I see 10% of patients receiving a TKI for EGFR ALK. How is that possible?
Sir, this was possible. This was addressed, and this was asked to a question to Patrick Ford in the ASCO discussion. So what happened was, I think in Asia, EGFR ALK testing was mandatory. In Europe, the EGFR ALK testing was not mandatory.
Why they put an inclusion criteria EGFR ALK negative?
Sir, but I mean maybe they missed it the PCR or something.
So what is the explanation? What is the explanation is that on progression rebiopsy, some of them end up having new mutations and hence the treatment was given. That is probably the explanation.
So new mutation nahi hoga, sir. Maybe they did a single gene testing which was missed by NG or something. But what the point you are saying is right, and that's the explanation which Patrick Ford gave it, sir, in the discussion.
That looked very dicey to me.
He said in the Europe it was not necessary. That's what he said.
Okay. So the conclusion is this that whether we like or don't like, Etrode is still the king unless
No. Conflict of interest. Please, you have to change your COI. You have to change your COI.
No, we don't know if after getting PCR we can stop adjuvant IO. We don't know that in TNBC also. So we will not know it soon, probably in a non-small cell lung cancer also. We don't know for PD-L1 negative, this patient this helps, but we still give it. We don't know what to do. If we don't get PCR, we continue same IO that did not work earlier and hope that with the time it will work. We don't have better option as of now. Unlike in breast cancer, ADCs don't work much in NSCLC and we still have a lot of scope for improvement. So that's my last slide. Thank you. And sorry for the interruption because of the bad internet. So I'm happy to conclude this and take any questions if they are there. Otherwise, we'll move on.
Once the delta really plateaus off, I just wanted to look at that.
I remember from RGCon, sir.
When I'm looking at all early lung cancer, Ullas, just look at it. It's the same thing as that.
You told that, sir.
Yeah.
Okay. Somebody's going to invite me or I'm going to invite myself? Vamshi?
Vamsi,
don't require
in the
invitation.
group,
You're already
invite
there.
yourself and start.
Okay, I will invite myself and start. Okay, can I please invite my panelists, Dr. Amol, Dr. Randeep,
I'm
and
there.
Dr. Soumya. Can you please switch on your video so that I am aware that, you know, everybody has not slept. Soumya is there, Randeep has all dark shadows and everything.
And they are not enjoying, and you are there sitting or in the and
Okay, fine.
I'm in another meeting. I have not gone home, so
Okay.
relax.
No worries, no worries, no worries. So I think after two very interesting panel discussion, let's deep dive into the inoperable stage 3 lung cancer. I'm a conflict of interest and disclosure this that I'm very, very, very scared of diving, but I'll still try to, you know, deep dive into inoperable stage 3 lung cancer. Otherwise, I have to, you know, swimming and me is totally two different things. So let's just set the stage set. This was the Pacific trial, which, you know, had a stage 3 non-small cell lung cancer patient, which after CTRT were randomized into between durvalumab and the placebo arm. And this is the trial which basically showed that there was a fantastic PFS and an OS advantage. That is what we all have been trying to get for. It's a 47.5 versus 29.1, 18 months OS advantage, which was seen with the Pacific trial. So this is the baseline which has been told to us by till the time of 2019, 2020. However, there were few unanswered questions after the Pacific trial. The one is, so let's just get over there. In the Pacific trial, we had people who came ahead and took CTRT upfront. So what could be the benefit of durvalumab after sequential CTRT? We all agree that immunotherapy is the most important thing. So why not jump ahead with induction chemotherapy or induction chemoimmunotherapy, followed by only radiotherapy and then give IO maintenance? Why not put immunotherapy ahead? What is the ideal duration of consolidation durvalumab? Where did 1 year came from? We had 3 months of 3 cycles of checkmate 816, 1 year of perioperative. Whether it is 1 year, 2 years, whether it is 3 years, whether it is lifelong, can we incorporate durvalumab as a concurrent radiation sensitizer? And what about the EGFR addicted lung cancer? That is what we are. So these are a lot of questions which basically came with. A lot of trials which basically said this. So Pacific 5 and 6 asked this. Pacific 5 and 6 also asked about the consolidation durvalumab. Pacific 2 is a very important trial which said, you know, a lot of people who said, let's go ahead and give immunotherapy along with radiation, no pneumonitis and everything. And LAURA trial obviously showed this. The very important trial where I really felt that, you know, we can actually go ahead and give chemoimmunotherapy. To me, this trial makes more sense. Small trial, the INTEREST trial was presented at ASCO 2025, which we'll be discussing. So I'll start with Dr. Soumya. Dr. Soumya, how many percentage of your inoperable patients actually are suitable for upfront RTCT? And how many times do you really have to, you know, resort to induction chemotherapy followed by, like, you know, tumor board, it says, पहले chemo 2 cycle दे दो, उसके बाद देखते हैं क्या करेंगे. Soumya?
Yes, sir. So when it comes to inoperable NSCLC, then again we have to discuss with the radiation people that whether they can give RT also to that particular. Sometimes the nodes are very in a critical structure. So if you ask me percentage, so something like around 40% of the patients probably will be around
Fantastic. 40% will be going for
CTRT.
60% will go for sequential RTCT. Randeep?
Many times it will go to palliative also, sir.
Fantastic. Randeep?
I think neoadjuvant is becoming less and less with IMRT is being used and the experience. Neoadjuvant before CTRT, definitely CTRT will be only 10 to 15%.
10 to 15%.
And sequential CTRT is almost less than 5%.
Oh, so induction, sequential CTRT. I mean, 2 cycles chemo, then you give RTCT, and then you give durvalumab. That is what?
So 10 to 15, maximum 10 to 15%.
15. Amol?
Half of them will go for concurrent and the rest will be sequential. So
this was the real world study that we basically got. And this basically said that even in Netherlands, Belgium, UK and Asian study, in fact, 40 to 50%, half or even more than that actually are going ahead with the sequential CTRT. And there are not many candidates for induction CTRT, which is there, which could be because of poor PS, you know, concerns about the field and toxicity and everything over there. So, I mean, this is what happens in clinical trial and what happens when I really want to paint Mona Lisa actually over there. So this was the Pacific trial design. I'm going to come to the other one. Very important trial design, which basically said sequential CTRT was okay. And what also it did was that durvalumab here was given till progression. So it is not that durvalumab has not been tried till progression, it has been tried till progression also. And this basically found out. So I'll just go to the trial once again. So you have sequential CTRT followed by durva maintenance or placebo. And this trial actually showed that 39.3 versus 30.2, almost similar benefit to what was seen in the Pacific trial actually. Median PFS of around 14 months, slightly lesser than of the Pacific trial. There was a trial, there was a comparison which was done between the PFS in the sequential CTRT and the concurrent CTRT. In the concurrent CTRT, it was similar to the Pacific regimen. So whether do we really need to give it for 1 year? Randeep, your thoughts on this? 1 year versus, we see that in EGFR mutant non-small cell lung cancer, LAURA trial, it's a systemic disease. There you want to go ahead and give it for, lifelong. Soumya said, a lot of people will go ahead with a palliative intent. But in durvalumab, we are giving for 1 year. Your thoughts on this?
Yeah, we can't compare the EGFR mutation positive, that is totally different biology and disease. First is that. Second is that, the question is 1 year versus what?
Indefinite.
2 years or progression?
Indefinite. This was indefinite. This was Pacific was there for indefinite.
Got it. This is an indefinite trial. See, even in the metastatic settings, we have been giving for 2 years now, and we are very happy with our experience also. It was first that the trials told us to do it for 2 years. We also started realizing that if you do it for 2 years, even if I have to design a trial, I may do it 1 versus 2, but not indefinite versus 1. So that will be my take.
So you will be happy with 1 year because it has not really added anything much on this. Amol, your thoughts? 1 year, 2 year, indefinite?
If cost is not an issue, toxicity is not an issue, indefinite. Same principle should be applied like LARA to this also. And we are giving in metastatic setting more or less indefinitely, or maybe at up to 2 years. So people do tolerate.
Randeep has a point. We give it for 2 years in this. And in fact, this trial did show, although number of patients were 200 odd and all, this trial actually said that, even if you give indefinite or 1 year, this trial doesn't really make much of a difference. And so I think in a stage 3 non-small cell lung cancer, 1 year of, durvalumab maintenance is absolutely all right. There is no need to really continue for it beyond that. Sequential CTRT, it was also absolutely okay. Now let's come to the ASCO 25 trial. This was an interest trial, which basically said you go ahead and give induction chemotherapy for 2 cycles. That is for tori plus chemo. Then you go ahead for definite CTRT, and then you go ahead and give tori for 1 year. So very, very nice design. I mean, you start with induction chemo radiation. People want to go ahead and then give only CTRT, no immunotherapy, and then tori. Randeep, your thoughts on this, the comments about the trial design?
It is a phase 2, but it's okay. We can go to, even if it's a phase 3, I think it is a fair enough because
phase 2 trial.
Because we have learned from Checkmate, from the 816 that 3 cycles of chemo IO makes a difference in N2 disease. So most of the patients who will be going for this type of trial design will be those patients who are inoperable or N2, N3.
Correct.
So I think if we are doing it for 3 cycles of nivolumab neoadjuvant in Checkmate 816, then this is ideal that we have to learn from that trial and adopt that we do 2 cycles of neoadjuvant or 3 cycles neoadjuvant. Also learning from Pacific as well as learning from head and neck trials where immunotherapy is coming up, the Nivostop as well as the other phase 2 data. They have beautifully done that. They have done CTRT and they have not combined immunotherapy here in the CTRT arm.
So that I think is a given now.
Sorry?
That's, I think, a given now. You don't combine radio.
Exactly. So that is why the trial design is, I think, good enough, the trial design.
Absolutely fantastic. Soumya, your comments on this?
So few things. One is that bulky part, a bit liberal on that part, the tumor size of more than or equal to 5 centimeter, or a node of more than or equal to 2 centimeter. I hope that that is discussed in the tumor board and then only they have taken, because there is no fixed definition of the tumor size of more than 5 centimeter. So that part I felt a bit of odd.
Absolutely right. Absolutely right. Amol, your thoughts?
So for a bulky tumor more than 5 centimeter with node negative, also they have included.
Yes.
So ideally it should be bulky and node positive rather than or. That's
Correct.
the only suggestion. Otherwise, the rest is okay.
I absolutely agree. The definition of inoperability was very lax as far as I can say. Most of these patients would actually go for a neoadjuvant chemoimmunotherapy and then for surgery also. So that was one. which came to mind. The second point was phase 2 trial, very small number of patients which were there, and only Chinese trial. It's not a global trial actually. The control arm was not really standard of care where you go ahead and give 2 cycles of induction chemotherapy. But it's okay. I think they really had to compare something with that. This was the efficacy after the induction therapy. And the objective response rates were pretty high, 77 versus 40. Soumya, happy with these kind of response rates? I mean, this is something which we see, or 2 cycles of Tori have added so much of objective response rate? How the disease control rate was absolutely all right. I mean, 96 and 92.
For me, it looks good. The response rates of around 80%, nearly 80% is good for this kind of setting, if it is really bulky disease.
Okay. This was the primary endpoint. Again, look at the number of patients. There were only 27 and 25, 52 number of patients were there. The median PFS was not reached. 1 year PFS was 85.6, HR of 0.26. But again, for the residents who are listening, just 52 number of patients. Amol, your thoughts about the primary endpoint, a phase 2 trial, small trial.
So if you exclude that there are less number, which is expected in a phase 2 trial, this looks pretty decent for an hypothesis generating taking into a phase 3.
For a hypothesis generating, taking into phase 3, not a practice
Phase
changing.
3. Not a practice changing at all. I don't take practice based upon 27 number of patients.
Randeep,
Not in lung cancer.
Or in clinical, see what happens in clinical practice actually is the surgeons and radiation will fight. You're not sure whether the patient will go for surgery or radiation. And finally, you say, we'll give 2 cycles of chemotherapy. 2 cycles of chemotherapy have never harmed anyone. Will you be tempted to add a Tori or a Pembro or something to your induction chemo rads and then see what happens?
That is a difficult situation, Ullas. I faced
That
this.
is a very common situation, Randeep.
It's a very common situation. It always happens that the surgeon withdraws your hand at the last time when you have started on Nevo chemo. I mean, you started on a neoadjuvant chemo IO, any drug, and then suddenly surgeon withdraws के तो फिर Nevo patient surgery के लिए, and then you are stuck. I think this trial gives you that confidence that if you have given neoadjuvant chemo IO, you will not be harming your patient. That is what I can take over. But yes, otherwise I echo with what Amol said. It is not practice changing. But if you are stuck in a situation that you start with chemo IO and now you want to continue Pacific or something like that, then it gives you confidence that you have not harmed the patient and manage it in that way.
Absolutely agree. So I will ask this question to Dr. Soumya. Soumya, let us say you have started the Checkmate 816 in an N2 disease. 3 cycles of chemo immuno have been given. The surgeon takes up over there, but finds out that the tumor is densely adherent. No surgeon will really want to, tell you pre-op only. And then they say inoperable. Do you think, is that situation common in your scenario, which is, I will stick my neck out and say it is not uncommon? I hope Datong is not listening to this. It's not uncommon.
Will be that part. So this question has been discussed many times in real world as well as in different conferences. I don't think that we have got a clear answer to that, how to go about. So especially post CTRT, how to go if you have given a Nivo plus chemo and then CTRT and then Durva, how to go about. It's a tough call. So I think that we have to discuss with the patient and then.
I think I agree with Randeep that this trial will actually give us some confidence. It will be difficult to change chemotherapies, whether you have given Nivo and then you have given, let's say, a Pembro and then go ahead to Durva maintenance. But still, there is some idea that, if you give radiotherapy, chemotherapy, and then you can follow it up with some maintenance. A very nice thing which came over here was that, the grade 3 pneumonitis was more, 11 point versus 4%, again for the residents. But the rate of symptomatic pneumonitis, was similar. That is what they said. If you look at this, they said the grade 3 pneumonitis was 11.1% versus 4% in the chemo arm. But the symptomatic pneumonitis was same. Grade 3 pneumonitis is when you are symptomatic, right? But if you look at the numbers, it was just 3 and 1. So for the residents, please have a look at the numbers. The biggest problem is if you don't have good sample size on this. That is important. This is what they wrote. No significant increase in symptomatic pneumonitis, but higher incidence of grade 3 pneumonitis. So don't only look at the Amol is there, so I should not be saying yes. Don't only look at the tweets and don't only look at the abstracts, read the numbers properly. Amol, agree with this?
Of course, the tweets are done so that people can read them, including the numbers.
So interpretation of this trial, Amol, for you. If there is one, you said hypothesis generating. Anything else?
Yes. Nothing more than that. We should test this in the phase 3 and then we should discuss. Right now, it is only hypothesis generating.
And I think a similar pembrolizumab was approved yesterday or today, the keynote 689, which again said 2 cycles of pembrolizumab before CTRT in head and neck and followed by maintenance pembrolizumab. So I think this actually says that, what is the best time to give immunotherapy? I think, Randeep, I'll come to you for this. What do you think? What is the best timing of immunotherapy concurrent with radiotherapy? Induction, concurrent, consolidation?
See, it depends upon tumor to tumor, but if you
Lung
ask
and head and neck.
lung, I will agree with this plan design. If I have to design a trial, that induction followed by consolidation, not concurrent, because many people believe that these 2 cycles sets the milieu of the tumor towards a hot tumor or an immunogenic tumor, and by the time you start the consolidation, CTRT, it helps, and then so these 2 cycles are just setting the ball or setting the ground for your immunotherapy to work. That is the hypothesis.
Fantastic. Soumya?
Today it is consolidation, maybe after 1
or 2 years. Fantastic. So I think I would totally agree. What I will not do basically is I will not do this. I think that's the first thing that, do not go ahead and, we see a lot of prescriptions for opinions in which they will be giving RT along with durvalumab or pembrolizumab, nivolumab. I think time and again we have proven if you have to give, if you don't have to give radiation along with immunotherapy, don't give immuno and radiation. Consultation, I agree with Soumya, absolutely the best evidence. But I think I agree with Randeep in this that, if I have to get a trial design, I need to give induction chemo, maybe induction chemo immunotherapy for 2 cycles, take it to the phase 3 trial like they did in the interest trial, and then take it forward from there. Even in Nivo, yes,
in head and neck, it is given induction, concurrent, consolidation. That is the approval for Pembro based upon that trial.
No.
Yes, he's right. Ullas, he's right. That trial, that keynote trial of Pembro included actually the phase 2 data of CRT said, but in this trial where the EFS data has come and they have given the approval, I think it is 6, 7, 8.
Go back again, Amol, and if you can
phase 3.
Just go back, Amol, if you can put the 689 keynote 689 into the chat box, just see it once again. I think it was concurrent Pembro was Vamshi saying it is there in the head and neck trial. Just see it once again.
Yes.
Okay,
yes,
fantastic.
it is there. I've checked it.
At least in
Plus, I have presented this in OBTO, I'm sure.
So I think okay, the one thing which I would probably say is induction chemotherapy. I mean, in lung space, induction chemo RAD. If induction chemo immuno, no RT with immuno, and then go for a consolidation one. That is what I would do probably. This is what.
Yes, the problem with the lung is that the pneumonitis is the issue. In head and neck and cervix, we don't get that kind of an issue. In head and neck, cervix also, it is given along with the radiation.
Fantastic. So I think there are 5 questions that we asked over there. We can consider giving durvalumab after sequential CTRT. We think duration of treatment is 1 year. Concurrent CTRT, no. And we obviously know that LAURA is there basically. And we want to have small number of patients. We have to get the larger global trials have to be awaited for this. This is LAURA. This is for you, Amol. This is LAURA trial, which was presented at ELCC 2025. At 48 months, you have 70% versus 52%. Fantastic 31% maturity. Your interpretation of this? This is LAURA trial, adjuvant osimertinib.
So yes, apart from that, it is given indefinitely. There is no flaw with LAURA. LAURA is a good trial, and those patients who are able to tolerate it and financially can take it, it should be continued indefinitely. I'm not against the data.
You will also look at this graph. So at the end of it, I know the numbers are less. Everything is less.
Numbers are very negligent. Only 6,432. So that is to be neglected. That part of the graph is to be neglected.
Absolutely. Small number of patients, too much higher censoring. But ultimately, I think living without disease, as we were discussing with the ADAURA and all, is very, very important in this. This was the thing about ctDNA. I think I'm not really going to go with ctDNA. This trial also showed that, if you have on durvalumab, if your ctDNA is positive at the cycle 4, that are the patients who are not really going to do better. I think my problem is we need to escalate and de-escalate trials. I think somebody should do a trial at somebody whose ctDNA is positive at 4 cycles. Did they then change the treatment to an ADC or something? And then that will really answer whether measuring ctDNA is important or not. It has to be also predictive and not only prognostic on this. Last 3 minutes. This was the trial, somebody's favorite drug here. Atezolizumab after chemo radiation therapy, prolonging survival in small cell lung cancer, limited stage disease. So in short, basically, this is the Achilles trial. And again, we give CTRT in small cell lung cancer. Then you give 1 year of atezo followed by observation. And this is in short, basically, this was Roche-ka Adriatic trial. And probably what we basically felt was that this is going to be equal. But Randeep, you are smiling a lot on this, so I will give it to you only. This trial showed that there is no advantage of atezolizumab maintenance, and Adriatic trial has shown this much. I did that in Opto. So there was this much amount of advantage. So what happened? Randeep, you are muted.
I was on mute. Can we go back to the trial design? I was aware of this, that this was a negative trial. I don't know what happened in this. This is a phase 2, first of all, but yes, if phase 2 has failed, it won't go. It is very difficult for the investigators and the company to carry it over. I don't know what has happened
You
here.
don't know what happened. Soumya, what happened here?
Frankly, I don't know what has happened.
If you were Roche, what would you say?
So I am loving the control arm more than the
Correct.
intervention arm. So the
You are loving the control arm more. The control arm did fantastic, actually.
Yeah,
Amol?
excellent actually.
I think they have the difference is that they have not taken those who have responded or a stable disease. They have given atezo to everybody.
No.
If
It
I'm
is
not
the
mistaken.
same. It is the same one. It is the same one.
But Ullas, if you go back,
If it is the same one, then my hypothesis is proven. It is a weaker drug.
I will show you some more graphs on this, actually. Yes.
See the numbers. If you don't see the stats, I think the number benefit is there in PFS, but not in OS. 15-20 minutes similar to Adriatic. 7-8 months is Adriatic, if I'm correct.
So the point over here, what exactly happened basically was this was a phase 2 trial, a smaller trial actually. One only it was a slightly more toxic trial basically. Very important thing with Soumya basically told over there was that the control arm did much more better. And the control arm did much more better because they actually said a lot of people got a doublet BDRT basically on that. That was very, very important. This is a slide that you will probably love, Amol. This is atezolizumab plus radiotherapy in all the cancer types. And by and large, nothing seemed to be working along with atezo and radiotherapy. So I'm not sure whether, there was a lot of talk about interchanging of immunotherapies earlier on, and we all used to say, we will extrapolate this data from that data and do. I think my conclusion from this is that we should not extrapolate one data set from other. We should actually continue and see what data is there in, and follow that particular, that trial. Like somebody was asking in interchangeability of immunotherapy drugs, that is something which I will not do. Amol, comments, thoughts?
Yes, I agree. We should stick to the trial data rather than changing from one IO to another IO. And we have seen that in RCC adjuvant. We have seen that in bladder. We cannot substitute one IO for another IO.
We cannot like it when we like it, and we cannot just change just because we basically like. This is also important. People who underwent PCI had a great PFS and the OS advantage over there. And this is something which is very, very important. BD schedule. I was never a big proponent of BD schedule. I felt that in CONVERT trial, radiation oncologists were saying whatever, but time and again, trials have actually shown that people who are, getting a BD schedule, Soumya did say about that. Soumya, your thoughts, comments about that?
Yeah, 70% in the trial received BD schedule. So even we are not practicing that, but I think that we have to look back and discuss.
I think I totally agree with Soumya. If there is a fit patient, if there is a patient who is absolutely logistically okay, you have to come in the morning and the evening. But I think across both Durva and the Atezo trial, one thing which has showed up is that people who have got BDRT have actually done much more better. Look at the Chinese data, sir. We will look at the Chinese data of small cell. One company is going to give us and show that data in another 2 months' time. So my conclusion, I think timing matters a lot in the context of immunotherapy and RT.
No, Ullas, I was speaking about the radiotherapy.
Ji, sir? Okay, I think I'll yes, Dr. Sahu.
I think he has been muted by somebody. Let it be.
Hello.
No, he's back.
Am I audible? Am
Yes,
I audible?
sir, you are.
Hello.
Yes, Dr. Sahu.
Yeah, I was talking about the radiotherapy Chinese data.
Okay, the
There's a
radiotherapy.
phase 3 randomized twice a day, 70 gray,
Yes.
and it is as good as giving immunotherapy.
Yes, yes. So I think we need to, I mean, from all this, both Adriatic trial and this, I have come to, I really think we should, wherever fit patient, we should encourage our radiation oncologists to give BDRT and be prepared for the toxicities. That is my take-home message from both the small cell thing. From the non-small cell stage 3, I am convinced that concurrent CTRT is not there. Induction is a very good approach. I think we will have more data coming up from that. Consolidation, definitely yes. Timing really matters on that. So with this, thank you.
I have one practical question that my radiation oncologist asked. If you give BDRT, are we supposed to charge them twice or only once?
If I was the administrator, I will tell charge them twice and don't give it to anybody after that. So leaving jokes apart. With this, thank you. Hand it back to Vamshi. Thank you.
Thank you, Dr. Ullas. As always, a fantastic presentation. So I thank everybody at the end of day one. We had a pretty healthy audience which has stuck with us loyally till the end. All thanks to the star moderators, I'm sure. So welcome back again tomorrow. We will look forward to welcoming you for 2 more sessions.
Superstar moderator tomorrow.
Yes, tomorrow is the superstar moderator and followed by one other moderator. So
Yes.
Thank you very much and see you tomorrow. Good night, everyone.
Bye.
So thank you everyone for such a wonderful discussion. On behalf of the organizing team, my colleagues Nishant and Gitika, it's time to say thank you, goodbye, and we see you tomorrow. Please do log in. Thank you.
Technical team, please